have two speakers discussing the decision-making process behind whether your child should have surgery or not. We are very honored to have Dr. George Ibrahim, who's a pediatric epilepsy surgeon at the Hospital for SickKids and an assistant professor in biomedical engineering. It's such a long resume, George. I mean, come on. He is also on our scientific advisory board. So I'm going to say lots of stuff, and he's on our scientific advisory board. Renee Charette is a mom whose son had a left functional hemispherectomy for stroke, and the two of them are going to discuss the decision-making process behind how you decide whether your child should have surgery. So welcome the two of them.
What I did is I removed this earlier. Yeah, hi everybody. If you were here at the last session, I was speaking as well, so thank you for not being so sick of my voice. I'm George Ibrahim, one of the neurosurgeons, and I'm really, really honored to share this podium with Renee, who is just, who I've known for many years. It's great to hear, you know, their surgery and it goes great and you go home the next day and you know, everything is wonderful. Those are amazing stories to share. But I think it's equally impactful and perhaps more impactful to hear about more challenging situations. So I'm really, really honored to share this podium with Renee, and we'll have a little bit of a chat about making the decision and have a little conversation between all of us.
Thank you. Hello everybody, lovely to meet you. Thank you for filling our big room with your big energy. I am so grateful that George let me join his event like last week. I was like, hey, can I come? And he's like, yeah, you can help. So that speaks to the relationships of trust that we're going to kind of elaborate on today. And I get to meet Monica today, who's one of my heroes, so that brings me so much joy. I'm so grateful to be here. To get started, I just wanted to acknowledge the land that we're on. So I'll admit that it's new for me to be in Massachusetts and Boston, and I've read quite a bit about whose land we're on, and I don't know that I'll even be able to pronounce the names correctly. So if anyone here is local and you can do so, please do honor with me. So folks including the Massachusetts, the Nipmuc, and the Thank you, Wampanoag. I would love to get to meet some. If you know anybody who lives nearby, has a story here that's unique and Indigenous, I would love to spend some time with them as well. If anyone's interested, one of my favorite books is We All Go Back to the Land. Suzanne Kiptu, she's Métis in the north, and I just wanted to share some pictures about my travels here. So on the way in, flew out of the Island Airport in Toronto, and there's two examples of displays of both Indigenous and Black culture that's being co-created and celebrated, and really just taking up more space in our community, and that's very important to me personally when it comes to health equity. So I just invite you to take a moment to reflect on who your ancestors are, how you got to be here, and the privileges that come along with that responsibility as well.
So I'm going to talk a little bit from my perspective about how I've tried to guide some families towards making surgical decisions that are appropriate and reasonable for them and for their children. And I put this figure because sometimes, you know, sometimes it's very clear what needs to be done. Oftentimes it isn't. And I wanted to, you know, this is not going to be a medical talk at all. I wanted to take about 5 steps back. And I'm going to really, I took a lot of inspiration from this article, The Seasoned Executive's Decision-Making Style. So essentially all families that are undergoing epilepsy surgery are going to be the seasoned executive, right? And this article is actually very impressive about how executives and CEOs make certain decisions and the different types of decisions that they need to make. Because the decision to have an epilepsy surgery is actually not the same among different families. It's actually completely different depending on the context in which you're making that decision and depending on the state of your child. So this article spoke to me, and it divided the way that executives or families with children with epilepsy make decisions based based on two axes. Some families have a lot of time to make decisions. Okay? So that's how information is used. You have lots of time to process information, and you can take months and months to make a decision about how and which epilepsy surgery to do. And some families have less time. On the other axis is how many options are available. So I kind of divided them into this 2x2 plot, taking a lot of creative license with this executive decision-making style guide. So some families have time to process information, and some families have many options, some families have fewer options, or it's very clear what the best option is, and for other families it's not very clear what the best option is. So if you take the first example, you have an unwell child, a child who is in status epilepticus, or a child that has severe daily disabling seizures. There isn't necessarily the luxury of time to think about what to do. There isn't the time to take weeks and weeks and months to come up with a decision about how to treat that unwell child. If they have a clear seizure focus, meaning that it's very clear what the best intervention for them might be, a resective procedure to resect that single seizure focus and the need for urgent treatment, the type of decision that you're making is a decisive decision. These are families that need to be decisive in the way that they make or approach that decision-making style. Decisive decisions rely on less information, meaning less time to process that information, with a clear course of action that optimizes the benefits versus the risks. It's focused on the task, it acts fast, and it comes across as efficient and firm. For a child who's in the intensive care unit, in status epilepticus with a clear seizure focus, there's really an opportunity for decisive decision-making to treat the child and have an enormous impact on that child's seizures. If you take the second example, say a child who is not in such an extreme condition, a child who's relatively well and potentially has rare seizures, and that child has a single seizure focus where you know or you're advised that the best option for that child is to do an epilepsy surgery to remove that seizure focus. The style of decision making for that patient is to prioritize decisions that stand the test of time. And that form of decision making is hierarchical. You have the opportunity to process all the options available to you and think step by step which decision you're going to make will withstand the test of time. And they define this as hierarchical decisions that are focused on ones that withstand the test of time. They're highly analytical and intellectual. So if there's a child with a clear seizure focus who's relatively well, it's not unreasonable to potentially consider maybe VNS or a different procedure, or you could take the time to prioritize and rank all of the options available to you. With a clear seizure focus, a resection would be preferred, but there's an opportunity to put a hierarchy of needs for that child and make the best decision. The third example is the unwell child. For instance, a child who is having developmental regression as a result of the seizures, where the cognitive development is stagnant or potentially declining. And there may be several options available. So, where there isn't a single focus in the brain it's not clear what the best surgical option might be. It's a child that needs urgent treatment, but it may require revisiting that decision. And that type of decision making needs to be flexible. If there's a decision that needs to be made urgently, but there's many options available, it may need to be a decision that's revisited. For instance, as we talked about in the last session, a child may undergo VNS, and the seizures may not respond to the VNS, and there may need to be some flexibility to consider other options such as RNS or DBS. Or a child may undergo RNS, as we talked about, for bitemporal epilepsy, and it may show that the seizures are lateralized to one side versus the other, and there may be an option for a resective procedure down the road that could be beneficial. It's flexible decision making that allows revisiting that decision and allows you to change course as needed. So this is focused on flexibility, adaptability. It allows decisions to be made quickly, but with the option of revisiting those decisions and reevaluating whether other options may be suitable. One of the classic examples of this type of decision making that I had a particular interest in is often the decision around epilepsy surgery in eloquent cortex. So say the seizures are arising from the motor cortex or adjacent to the motor cortex or the occipital lobe and the visual cortex, critical areas of the brain that subserve some function. There's many options available. The two primary options are resective procedures and, as we talked about in the last hour, RNS. And 10 years ago, we wouldn't be having this conversation. The only treatment option for these types of epilepsies was a resective procedure. And in fact, it was quite common to have resective procedures in eloquent cortices, accepting a deficit before RNS became commonplace. And these are the types of decisions that need to rank the different pros and cons and to be flexible, to revisit the advantages and disadvantages of subsequent decisions over time. So for instance, with resections, there is the benefit of seizure freedom, that the goal of a resective procedure is to abolish the seizures completely, whereas the goals of RNS is only to reduce the seizure burden. The long-term outcomes of resective procedures are relatively well known. There's over 80 years of experience with resective procedures, whereas RNS, I would say its long-term outcomes are fairly established now, but they're still nowhere near as comprehensive as the outcomes with resective procedures. The resections are permanent, so there's no way to reverse those procedures, whereas with RNS, there is reversibility. You can adjust the stimulation up and down, and access. Several years ago, resections were readily available. All epilepsy surgeons were able to do resective procedures. That was the bread and butter of what epilepsy surgeons did day in and day out. And RNS, I talked a little bit about access in the last session, was fairly inaccessible to most people. I will say that in the last few years, there's almost been a shift, especially the younger epilepsy surgeons that are being trained probably have more comfort with RNS compared to resective procedures. So we might actually see a complete reversal of these access trends in years to come. But these are the types of potential considerations that might lead to flexible decision making. So for instance, if there's a child who's really unwell with a seizure focus that's arising from an eloquent brain region, maybe RNS is a very reasonable first choice to make. Right? And then if the child remains unwell and the RNS doesn't achieve the benefit, maybe a resection is something that needs to be weighed in terms of the pros versus the cons and in terms of where the seizure focus is and how it might affect the quality of life. So this type of decision-making, flexible decision-making, relies heavily on the ability to weigh the pros and cons and to be able to modify decisions based on new information over time. The last example is an example of a well child who, for instance, a child that has rare seizures that are quite stable, that haven't been changing, a child that's developing typically, and one that has several treatment options available to them. For example, neuromodulation, as we spoke about at the last session. These types of decisions need to focus on quality of life, risk mitigation, and weighing the different options. So this type of decision making is integrative. Lots of information and data are available. There's many options, broader uses, get inputs from multiple individuals. Often these are families that seek multiple opinions from different neurosurgeons. And as we heard, 5 neurosurgeons will give 6 opinions. But these are the types of contexts where it's very reasonable to seek out different opinions before you finalize your first decision. And of course, none of these decision-making styles are mutually exclusive, but I put this 2x2 table to really emphasize that no 2 decisions about epilepsy surgery are the same. Decisions about whether or not to proceed with epilepsy surgery, what type of epilepsy surgery, is really contextualized within what's going on with the child and with the family. And there's opportunity for decisive, hierarchical, flexible, and or integrative decision-making when approaching epilepsy surgery. This is a very reasonable integrative decision-making model, right? And it really requires 2-way, honest, and comprehensive conversations with your child's teams. And this is a slide that Monica had put together several years ago that I'm adopting for this slide. So it really involves identifying possible treatment options, pooling together what the opportunities are, involving multidisciplinary groups, sometimes involving multiple opinions, as I mentioned, from different centers or different surgeons, and then distinguishing differences in the treatments, looking at the values of the patients and the caregivers from the lens of the care provider. How much do patients and caregivers want to be involved? What to do? What do they want to know? And ranking all of the different options based on the values of the caregivers in terms of what they want to know about all of the different treatment options. And then once they're ranked, evaluating whether one option is better than the other, and reviewing and evaluating at a later date with families based on their personal values. So this would be a very typical integrative model for how to make decisions in that 2x2 table for integrative decision-making styles. I do want to talk a little bit about some of the work that we've done looking at how families and care providers make decisions around neurotechnologies for epilepsy surgery. Because as we talked about earlier, there's many treatment options, and there's really no right and wrong choice about what to do. This is a study that I was a part of. Judy Illes is actually a neuroethicist who works out of the University of British Columbia, and this was part of an NIH grant that she received to study how clinicians and families make decisions together when it comes to the treatment of DRE in children. And she did multiple focus groups, and we ran them out of multiple society meetings, and we had many focus groups with families, and essentially we pooled them together into these categories. The number one factor that weighs into decision making for families is the risk versus benefit, which is self-evident. Right? The perception of the benefit, the perception of the risk, and the risk to benefit ratio are the number one factors that families consider when coming up with decisions about epilepsy surgery. The second most common set of factors related to epilepsy surgery are relational. Do the families trust in the clinicians? What is the child's disposition, and what are the family dynamics? All of which factor into the decision making that families pursue surrounding epilepsy surgery. The third theme that arose is the context. Both the context of the technology that's being proposed or the treatment that's being proposed and the context of the child's epilepsy. Is there access to the different technologies? What's the responsibility or burden related to the epilepsy? Is there support for having this procedure and for undergoing the intervention? Is there time and social stigma factored into this as well? And the last set of factors that weighed into family decisions are online resources, peer support, advocacy, and evidence. And I can tell you that just about every single family that has epilepsy surgery in Toronto is connected to this organization and is connected to Monica Jones. And this organization has been a tremendous, tremendous source of support, advocacy, evidence, and online resources for families, all of which are critical to making these decisions. So just an overview of choice and trade-offs for parental decision-making when it comes to pediatric epilepsy surgery. With that overview, I'll pass it over to my co-speaker, Renee, to share her family's journey.
All right, so I'll start just by going a little bit into who I am, how I ended up here, and I did my best to try to do a timeline for Kieran. It became this like deep, complicated, immersive exercise, and by the end I wasn't even getting the numbers right, so I'm not sure it's completely accurate, but it's my best attempt. I'll go through it a little bit. So you've seen the photo, the tallest one here, the Star Wars toque, that is Kieran. He's 8 years old. He was born in 2016, and he has a little brother named Riley, who just turned 5. So this is really incredible to us that they've both come to build a relationship and have independent identities and really social skills at all in terms of being able to play together. We love the nature, we love being outdoors, everything to do with playing outside, jumping in puddles, that is our jam. Before I dive into the story about Kieran, I just wanted to share that I was recently on an out trip, so I love canoeing, camping, with a good friend. And she has epilepsy, she's had many EMU stays over the years. They've never been able to identify exactly what it is that she would need surgically. And her story is one of pediatric epilepsy, but from years ago. So she's around 40 now, and it's really impacting me to see the contrast in what options were available to her then, how it's impacted her adulthood now, as compared to Kieran's story. So current state, she has a little one, same age as Riley. They live together. We call them our triplets, basically, 4-year-old triplets, because our 8-year-old's more like a 4-year-old. And the last time she had pretty severe epilepsy or seizures was during labor. And after that, she was pretty okay. We hadn't seen any. And when we were on a camping trip, she had about 18 hours of being completely unconscious and seizing. And as much as I'm trained in wilderness first aid, I take a lot of out trips with youth. This was a very different experience and was really eye-opening. So we were able to evac safely, took a really bumpy ambulance ride, luckily didn't need an airlift. She spent a night in critical care. Next morning, other than me trying to fill in all the blanks for her in her memory, like she wanted to know where her docs were my boots. I'm like, do you mean documents, like medical documents? She's like, no, I was wearing the docs. I'm like, no, you weren't wearing the docs. But honestly, it's incredible. It took like a 6-person carry to get her out of the woods, and she's all good now. She got to go home, was working the very next day, but her license is no longer coming to her. And she had fought for years and years to get back. So these decisions that we make for life or death have incredible impact. And in her case, her febrile seizures when she was a baby, she would have been about 2, she would never have had these options that are available now. So it's pretty incredible to think about the privilege that comes with being born here and now, and in Canada having access to care. There's no way that what I'm about to tell you would be possible if we didn't live in Canada, if we weren't born in this time. So Kieran was my first kiddo. His dad and I were both child and youth counselors. We thought we were good to go. No matter what developmentally came our way, we were ready for kids. And then he threw us for a loop. Everything was normal through pregnancy, had no idea. And at 6 weeks, we heard a heart murmur, which any of you who live in the CHD world, congestive heart disease, know a heart murmur could be very unimportant, benign, like just cash, or serious. In his case, it was very serious. He had about 10 different defects, so it was considered very complex. They created an MRI of his heart, a print to try to decide what to do surgically. He essentially didn't quite fit the mold, but we planned to take a 3-stage palliation surgery route for cardiac surgery, with the goal of getting to something called the Fontan surgery. So this is a bit of what went down. So emergency C birth, nobody noticed, he was all good to go, he went home. CHD diagnosis came, multiple diagnoses. We started following the single ventricular pathway, so he had very intensive care at SickKids Hospital in Toronto. He had his first open heart surgery in June, he was born in April. Many things were done, and none of them were like standard, all just different things that they had to do. As is Kieran's nature, after his first surgery, he bounced back down to critical care, and this is the pattern. We learned to see his rhythm. Spent about a month every time in surgery, bouncing back and forth. Then, lots and lots of care as outpatients, started to feel like we were a family at home a little bit. He went in for heart catheterization. They realized that one of the bandings they had done in his LPA, left pulmonary artery, he had outgrown it, so it had shifted, and that explained a lot of loss of oxygen. And for context, like his oxygen rates were very normal when they were in the 50s or 60s, which is not something that the majority of us can wrap our heads around. And each stage of surgery would kind of get him more access to perfusion into oxygen, but his body wouldn't be able to manage, like there was like a top, like he couldn't go over 80%. It wouldn't be safe for him at certain stages of surgery. So we ended up getting a heart cath done, figuring it out. He developed an allergy to contrast dye, made it more interesting. Had another open heart surgery, was not the one we planned, so we weren't at stage 2 yet. This one was more complicated, lots of risk. He ended up on ECMO. I don't know if any of you have experience with ECMO. That's more of a cardiac thing. It's essentially the most incredible machine with the quietest sound in the critical care unit. And it was keeping my kiddo alive, and it was really amazing to see the test of spirit every time they would unclamp to see if he could actually be able to sustain that anatomy alone or not. So just replumbing his heart again and again. Classic Kieran style. He got through ECMO, went upstairs, code blue, back downstairs. 2017, so the first year of his life, he'd gone through all of this. He had a heart cath. Had another allergic reaction. We changed our diet. I was breastfeeding for years and years, changed my diet while living in hospital. Colonoscopy, couldn't figure out why bloody stools, but that's okay, let's go forward with the third open heart surgery, which was meant to be stage 2. This was one where things were difficult, but we didn't realize how difficult. It's called the Glenn procedure, and it is quite risky. Essentially, they were replumbing his upper vena cava. And in the process, we parents picked up on things not being right and were able to flag to the team that we thought he had had a stroke. The team didn't believe us. We had to convince them. They did an MRI. The MRI team was like, no, you'll be good. And then they came out to say that most of his left brain was gone. So it was a major stroke, left MCA, M1 division, if any of you know what that is, day 4 after surgery. He developed seizures immediately, but they were subclinical. So it wasn't obvious that he was having seizures. So that enters in this layer of confusion with perceiving things that we know are there that science can't capture, and this dynamic of what role caregivers can play. His first birthday was spent at SickKids. I missed my grandma's funeral because I wanted to be there with him. Eventually he went to Holland Bloorview Rehab. If you want to know about our rehab, it's amazing. It's in Toronto as well. Lived there for a month, very difficult for us. A lot of other things going on in our lives at that time, personal things, lots of deaths, becoming responsible for older family members, taking on a lot of layers. He was put on blood thinners proactively to prevent another stroke, continued to have seizures. We went through all the medical trials. So if y'all have been there, many medicines, go. None of them were working. He had a whole range. He had drop seizures. He was having about 10 a day. He would learn how to stand, fall, hit his head. After the stroke, he had to relearn all the developmental stages he had learned at his own pace, but it took a long time. And what really changed things for me was conversations, I think, with 3 people in particular. So Dr. Ibrahim, who's here, Monica, who's here, and Dr. Weiss, who continued to follow us afterwards. I think those are the people that really brought me a sense of peace and trust in a decision I thought I could never make, that I really couldn't wrap my head around. So with open heart surgeries, as much as he was unique, the doctors always kind of seemed to have a plan and know what they were going to do. But what we didn't know was if Kieran could have this epilepsy surgery with the stage of heart anatomy he had, or if we had to do the heart first or the brain first? And it became this incredible, complicated question of what do we prioritize, what do we save? Monica, when I called you in a hotel room with one of my best friends in Ottawa, just randomly dialed you up. To me, that's such a clear example of peer support. And what you gave me was something that no one else in the world, not a medical professional, could give me. It had to be somebody who had walked it and lived it and could see it from the other side. And that's why I'm here today. I want to be able to offer that perspective to others. Dr. Weiss, who isn't here, she was the one who explained to me that his brain was going to not only slow down his development, but eventually deteriorate, and that there wouldn't be a cure to enjoy, so that we had to do the brain surgery first. So we pulled all of the resources together, research, consult, leaned into stroke. Any knowledge was mostly from adult population. There were examples of Hemis being done on someone with Fontan stage of anatomy. You'll see that's where he's at now. After 2019, he did get that stage of surgery, but it hadn't been done in the Glenn stage, so we didn't know if it was possible. So we took our risk, and as my ex and I both are very strong advocates in the mental health field, we pulled everyone together for yet another interdisciplinary conversation, and I was really amazed to see neurosurgeon Dr. Ibrahim and Dr. Van Arsdale. I don't know if any of you know the heart surgeons. He and Dr. Ibrahim were sitting together and literally just doing the math, like trying to figure out what the pressures were, what the risks were, and giving a best guess. And this is what matters most to me, that there was a willingness to take that extra step to kind of step outside of scope of practice and find where that overlaying zone was and collaboratively take responsibility. So to get together, they said it'd be cool to go ahead, which we did. Tried not to take out too much brain so they wouldn't mess with the pressures. Was done beautifully. And I have fears that he's having subclinical seizures, but there's not been any medical evidence since then that he's having seizures. So I live with that and ask those questions every day. But it allowed us then to move forward with other things that he needed. He needed a G-tube to build up enough nourishment to be able to get to his last stage. So the Fontaine stage of anatomy for his heart was done during the pandemic. This essentially prolongs his life. He wouldn't have lived a year without surgical intervention. This prolongs his life into adulthood. Glenn's second stage would maybe have brought him into adolescence. So our kid, who we didn't know had any issues, who then we didn't know could stay alive, we are now planning for his adulthood. And it's a lot to wrap my head around. But I would say out of everything we went through, the decision about brain surgery was the most difficult. And I'm happy to answer any questions and talk through that. If you want to know more details, all the medical science is published in an article, so feel free to look that up. I tried to refer back to that for my timelines, but I'm primarily oriented towards mental health, and trauma-informed care is my bread and butter. So if anyone else has understanding of trauma, it can be really difficult to work through those memories and to manage the dynamics of emotions and logistics both. So I'll leave it at that, and I'll pass over to Dr. Ibrahim. Happy to take any questions as well.
Thank you so much. So, you know, I could stand here and I could talk for an hour about decision making, but I'm so honored and so grateful that Renee spoke and shared her story, because it's very easy to talk about an epilepsy surgery, a minimally invasive procedure, and you know, next day everything is okay. It's very different to talk about these types of decisions, and Renee, you are such a strong advocate for your little guy, so it's really an honor to share this stage with you. And I think that your story involved all of these decision-making styles. There are times when you were decisive, when you made clear, immediate decisions. There are times when you weighed the different priorities and were hierarchical. You were clearly flexible in your decision-making and reevaluated how things are integrated. And you brought everybody together, which was, to your credit, these multidisciplinary meetings involving multiple care providers making complex decisions. And let me tell you, I learned a thing or two about the heart after all of that process. So really, I think this epitomizes what decision-making around epilepsy surgery is about. And I think I'll stop there and invite you to come join me, and we can have a discussion with the group for the next few minutes before people go for dinner. I know we're the last step before dinner.
I'm going to cheat a little bit and ask a personal question, if that's okay with everybody. My son was left modified lateral hemispherotomy UCLA approach at 3 months old for hemimegalencephaly. Seizures returned a year later. We did a revision. Seizures returned almost immediately. I could not stomach a third surgery, an anatomical. I was frozen. It was traumatic to even think about it. And in that time, he lost all spoken words and has never spoken to me again. And it's my biggest regret in this community, you know, out loud, when I'm counseling other families, when I say, and then I did this and my son can no longer talk because the seizures wiped everything away. I think I'm looking at you, Renee, because we've connected before. How do you do all of this, the Harvard approach to everything, while being frozen with fear or trauma? It was really difficult because I feel a little similar to you. I can be really cerebral about things. I could not work to that third surgery. So how do we as parents navigate that terror that we have of doing it again?
I brought a few things with me that I'll just circulate. I'll just mention what they are because they help me. Maybe they'll help you, maybe they won't. One is a training I went to by someone named Winston Blake, and he was taking a collectivist community's approach to the 5 stages of change. You've maybe heard of 5 stages of change more in a Western model context, but this one centers children and youth and their understanding of coming into community. So I'll circulate that. You can have a glance through it. It might be just a different approach to looking at things. I'm also going to circulate, just ask that you don't take pictures, a really complex care plan that we had created with the paramedics in Toronto. Very few of these exist. What it allows is for us to receive a trauma-informed care approach for our child. And it's things that may make no sense to a randomer, but if you've been in our situation and you understand what they mean everything. To create options and adaptations, right? We have something at SickKids called the disabilities team. As soon as we have that kind of compassion and understanding, whether it's from professionals, whether it's from peers, whether it's from loved ones, friends, anyone who can really step into that confusion with you, a therapist, help us to regulate, co-regulate, it makes a world of a difference. So feel free to have a look at these as I chat a bit more and answer. I think it all depends on what makes you resilient. So for me, resiliency has been about community, has been about advocacy, has been about connections, has been about the things that help keep me sane, nature, mindfulness. So whatever it is that makes you you is what's going to help you to build resilience, have a widened window of tolerance, so that you're not roller coasting up and down between hypervigilance and hypovigilance. So that freeze state you mentioned, right, where you don't even know, I'll be honest, that was me today. The panic of like, I want to come, but I can't come. I'm going to take my time, but I'm going to get there, right? It took so much time for me to be from one place to the next, and to lose track of time is very common in that state. We have dissociation. I'll hear things like, I drove from the hospital all the way home hours and I don't remember the drive, right? So understanding that we're not always present, and that if we're in a hypovigilant state, right, it's about us needing to come back into our window of tolerance. For some people, it could be as easy as playing some funky music that makes them dance. It could be giggling with a friend, right? It could be jumping jacks. It could be coloring, whatever brings up that energy. If you're in hypervigilance, you want to fight, right? Or you want to run away. Notice that, honor that. The number of times that I've had panic attacks in the hospital and I just run up and down the stairs. And it brings me back to when I was an adolescent medicine, child and youth counseling intern. and they weren't allowed to take the stairs. You know, there was rules around the stairs, but just this feeling of choice, agency, movement, right? Being able to find places where I felt authentically myself, running to the trees, these little micro moments of reaching for help and giving ourselves permission. Those are the things that help me, but it really depends on what will keep you grounded and how you can build your resources.
Okay, it's for the recording.
okay.
Yeah.
Amazing journey, story. Thank you for sharing. I can't imagine all that you've been through, and I'm sure this is just kind of scratching the surface. You've gone through an awful lot of decisions, and one thing that I think my wife and I struggle with, even though we haven't had some of the major decisions that you've had, is going down the rabbit hole of second guessing yourself later on. How do you pull yourself out of that? Because it's something that we really struggle. My God, we should have done something 2 years ago or something. But are you okay just kind of blocking that out and saying, this is what I've got now, and you move forward? I'm kind of curious how you deal with that.
It's a great question. Depends how much space I have from the moment, right? Like if I'm in a hospital, like some of those moments I mentioned, I was getting all of his documents printed out, up all night, bedside, highlighting things, looking for mistakes, trying to figure out what, doing the research, taking a course on French translation, medical, just trying to learn different ways of learning to try to see how I could see the problem differently. Whatever I could do, whatever felt like it was in my control. And sometimes it was probably extremely frustrating for the medical teams because I didn't want to accept an answer. I wanted to make sure that all the answers were considered. So I can respect and understand that need to kind of resolve or search or come into peace. On the flip side, the teams that helped me the most are those that were interdisciplinary. I don't know what you have access to, but the ones that were designed with interdisciplinary lenses, because these teams understand the whole self. So I leaned into the spiritual team, right? The palliative care folks, they helped a lot to teach me about surrender specifically. And the complex care team, they really helped me to coordinate because a lot of this executive function I didn't have capacity for, even just to sort out how we were going to stay alive or feed our kids. But just thinking about Emancipation Day, we celebrated it yesterday in Canada, and the speech from Nelson Mandela that really kind of speaks to that spirit piece. Some of you have heard it before, I won't read all of it, but our deepest fear is not that we are inadequate. Our deepest fear is that we are powerful beyond measure. It is our light, not our darkness, that most frightens us. We ask ourselves, who am I to be brilliant, gorgeous, talented, fabulous? Actually, who are you not to be? Sometimes it's accepting all of our power that can be overwhelming, right? If we actually have this much access, the only reason I had this much access is because of my privilege, right? My education, my color of my skin, right? My fluency in the language. Without those things, I wouldn't have the access. So knowing what you have and what you bring to lean into. And the other piece, as we are liberated from our fear, our presence automatically liberates others. So knowing that as you come into that peace is a gift also to others. But the surrender was really just having to let it go.
I'll maybe add one small. I don't know if I can add much to that, and I certainly lack the insight and I have the reflexes.
I don't have the 5 meter, so team.
Just on your comment about second guessing yourself, I actually really appreciate it when families come to me in clinic and say, well, gosh, Dr. Ibrahim, did I make the right decision to do DBS, or did I make the right decision to have the VNS implanted, or did I make the right decision by not agreeing to those things? I actually really appreciate that honesty, and I think those are probably the most useful conversations that I have with families, because we really reevaluate the priorities that went into those decisions. And one universal statement that should go without saying is that everybody makes decisions in the best interest of their children. Information might change, new knowledge may be gained. In hindsight, maybe the decisions weren't the best, but they were made at the time with the best interest of the child. And we explore those decisions, and I guess the point of all of this is to encourage you not to hold those in, to share those types of doubts and second guesses with your care team, because I think they'd really appreciate hearing them.
And if you don't feel safe telling your care team, and there's someone else you feel safe telling, like a mental health professional, that's important too, so that we're not poisoning ourselves with that regret.
No. Okay. Hi. So after some conversations today and also the session that we just went to with the Courageous Parents Network, they're talking about decision making and kind of like your own personal style and the style of like your care team and things like that. I'm wondering, especially for people who are considering surgery where there are lots of options and some doctors take the approach where they're like, well, I suggest this without kind of expanding on the reasons why. How do you both suggest working with your care team to make sure that you're both on the same page, that they're giving you all of the information you need to comfortably make that decision when it might not be consistent with their style?
That's a great question. I think everybody has different styles, right? And everybody approaches problems and solves problems differently. I think it's really important to communicate that well, because sometimes I've had this situation where I think a conversation goes great, and I think I've explained everything perfectly, and I walk out of the room. And the next day, my nurse practitioner, who is outstanding, says, "Well, I got an email from the family. They really didn't understand anything about that conversation." So I think everybody, really has the best intentions, but sometimes the communication just doesn't click, and it's really important to make sure that you're completely satisfied with that communication before making decisions. It's rare. To need to switch to a different provider. I truly believe that the vast majority of these issues are just issues that develop as the relationship develops, as you continue with your provider, as you get to know them, and as they get to know you. And I know, families that I've followed for years, I know what sort of communication style works for them and which don't. So some of these things are learned with communication. Very rarely you might need to switch to a different provider, but I think those are extreme situations. But speaking of people who advocate well and bring people together to communicate effectively, Renee, maybe you have some comments on that. I think you have to hold this for the...
Okay. Do I hold both?
I think so. All
right, you can hear me. I pulled another resource from a training I did, again, with Winston Blake. And it's an easy one you can use with kids. That's why I'm a child and youth counselor first. I always think about how do I explain this to kids in a way that it's accessible. But basically, it's conflict styles. How do you respond? And then the images are a shark, an owl, a fox, a teddy bear, and a turtle. The turtle's avoiding, so this is less focus on relationships and less goal-oriented. The bear is accommodating, that squishy teddy bear. That's really relationship oriented. And then there's the shark that's really oriented towards goals. There's compromising in the middle. There's collaboration in the top, the owl. So similar to what Dr. Ibrahim presented, it's this idea that we don't all, regardless of what type of decision you're making, we don't all come at decisions in the same way. The turtle is one, for example, that is quiet for a very, very long time, but then when they do speak, they succinctly say the truth from a very big picture and wrap around a lot of the other perspectives. So just notice how you're responding to something. Is somebody showing up as a shark and it's triggering to you? Can we reframe that and accept that this is how they know how to manage conflict, and that there's other options, and that if I'm vulnerable about how my needs are, what I need to effectively communicate and make decisions together, then maybe we can create a middle ground to build that trust and maintain those relationships.